All right, whenever you're ready. Thank you.
All right. Did we let everybody in already?
We did, yeah. There's 17 people on.
Okay. Hi, everybody. My name's Natalia. I'm a fourth-year medical student at Florida State, and I'm really excited to be on this panel today. So without further ado, I'll let everybody else introduce themselves.
I'll go. My name is Chuck. I'm a fourth year at Texas Tech on the Amarillo campus, and I'm going to be applying, dual applying family medicine and psych, as well as combined programs for both of those.
And hi guys, my name is Courtney, but everybody calls me Kiki. I'm a fourth year medical student at Miami Miller School of Medicine, and I'll be applying to psychiatry.
Awesome. So we'll just go ahead and dive right into the slides. If you have any questions while we're doing the slides, feel free to stop us and ask. If not, you could save your questions for the end and we can answer them at the end as well. So, these are our emails. This is being recorded, so this will be shared at the end on the LMSA website. Feel free to email us if you have any additional questions that we didn't get to. And then these are some basic tips for any rotation. Feel free, the panelists, to jump in at any time if you have anything to add. But really, just make sure you contact your preceptor ahead of time. I think this goes for any single rotation. Introduce yourself, make sure you find out where you need to show up, what you need to wear, and try to be there early because that's typically what's on time. Professional behavior, as always, professional attire. And again, ask to see what they prefer. For psychiatry, maybe you guys could speak to this, but I didn't use my stethoscope at all compared to other specialties. But you definitely want to have like a notebook and a pen to write with. Know what the expectations are going to be because every preceptor is different. Make sure you ask for feedback in the beginning, in the middle, and at the end. Complete all your assignments early so you don't have to worry about them at the end when you're studying. And then always offer to do more, show up, be proactive. And regardless if you think you know what you want to do, like going into psychiatry, or maybe you really don't want to go into psychiatry and that's something you think, just always keep an open mind and a good attitude. And HIPAA, of course. Anything you guys want to add?
Yeah, the thing about the attitude I think is the most important because psychiatry is definitely like a field that isn't really like anything else. And so when you go in and you know what you want to do already and it's not psych, there's nothing wrong with that. Like we all have our different passions, and I actually didn't expect to like psych as much as I did. And then I fell in love with it. But the people who are in your program, the residents, the attendings, your other students, like they're not dumb. They're, we're all here because we have a level of intelligence and we understand people, and people can tell when you think you're above something or when this is a waste of your time or you're too good to be here. So just like go in every day, appreciate how unique psychiatry can be and the skills that you learn that you can apply everywhere else, because there are a lot of those, and we'll talk more about those later. But attitude is a huge thing, I think, in any rotation, but psych too.
Something I'd like to add specifically for psych rotation is it's very difficult, I think, at the beginning of the rotation to learn how to start having these conversations, especially if you have someone who's suicidal or going through a manic episode. It's very hard to know how you approach the conversation and ask some of the difficult questions, especially if someone's in a crisis. So I definitely recommend, at least in the first couple of days, ask your psych residents to come with them and like see how they start having those conversations. How do they approach it? And also asking your attending, because sometimes every attending, especially in psych, has a different way that they like to approach certain conversations. So I recommend showing that type of interest when you first come in, saying, how do you have these conversations? Because it's difficult.
Awesome. Now we're gonna get into the specifics for psych. In medical school, a lot of people refer to psych as psycation. So we'll kind of dive into that. Is it a real thing? Yes, in a way, because psychiatrists tend to have one of the more lax schedules compared to other specialties, but that doesn't mean that it's not difficult. That doesn't mean that you want to wait until the last week to study, because it does catch up to you. That being said, a lot of people do very well on the psych shelf. So it is more difficult to honor it if that's something that is going on at your institution. And every institution's a little bit differently. At FSU in particular, you had to score above the 75th percentile. And then you also had to have really good evaluations in order to be considered for honors. I don't know if you guys had a little bit different experience. What do you think?
So my thing about, so I will agree that the test is, I wouldn't say easier, but the material is more condensed to where you don't have as much to cover when you're studying. A lot of the pharmacology and the pathology in psychiatry is what you learned for step one, if you've already taken step one. So it doesn't really go too much farther than that. But I don't know if it's just because I'm biased because I want to go into psych, but I hate the word psychiation. I get super salty about it just because I don't think that, I mean, it's chill in that you're working with psychiatrists, and psychiatrists are more likely to value your mental health and let you kind of express yourself as a med student in different ways than in other rotations. But I think that there's a lot of emotional weight that is carried. You know, you're seeing patients that are actively suicidal, who struggle with like chronic bipolar disorder, you know, substance abuse, all kinds of things. And it's a lot. And since, I mean, I don't know about you guys, but this was my first like psychiatry clinical experience. And it was like, I had to learn not to take it home with me every day. And honestly, I'm still learning to do that. So I think that it was just as hard as the other rotations, just kind of in a different way. But that's just my experience.
No, I 100% agree with that. It was my first rotation, so I didn't really have anything to compare it to. And it wasn't until after I finished psychiatry that I realized how much emotional toll it took on me. Like, I was like, wow, I really, you know, it was a lot of, I guess, like mental fog.
So I like to add a little tip. If you're interested in psychiatry, I actually think it helped me set me apart from my peers by people coming in thinking that psychiatry is an easier rotation or thinking of it as psychiation. So for me, you know, a lot of med students that you could leave before 2 p.m. if you wanted to, specifically on my rotation, but I was always there till beyond 5 p.m. And I also got to ask like my attending if I could, when we're done with our rounds, if I can go to crisis, which is at Jackson Behavioral Health. It's like our ED specifically just for psych patients. So I was able to show my interest, especially because my rotation is only 3 weeks for psychiatry. That's it. So with having that limited amount of time, which is most of my rotations are 6 weeks long. So I think you can really make it a benefit for you by having other people maybe take it a little bit easier. You can really stand out and show like why you're interested in it. So.
All right, so what is the structure really like? It definitely varies. As Kiki was saying, hers was 3 weeks at her institution, but at Florida State, ours is 6 weeks, like every other rotation, so it kind of varies. But you definitely have a mixture of both inpatient and outpatient medicine. For psychiatry, inpatient is typically known as like, you know, the wards, or some people refer to it as that, versus outpatient is more like routine visits. You tend to see a little bit more patients that are stable, a lot of med refills. So that's what outpatient is like. And then inpatient, you're kind of doing, like Kiki also said, like your rounds with the residents or with your attending. It's a higher percentage of underserved and lower income, underinsured patients, people that have lost access to their medication or maybe ran out of medication, are in a crisis, as Chuck was saying. And so you kind of interact with these, I guess, more people in a crisis, for lack of a better word. There's also several Baker active patients or patients that may not have insight on their illness, and their parents or their family or the cops found them and felt that they needed medical attention, so they brought them in. So those are the different kinds of cases that you'll see and what the schedule is like. And like Kiki said, at some institutions, you might be done before 2 o'clock, you might be done before 11 a.m. And you can dip out, and that's on you. Or if you show the extra interest because you're really interested in psychiatry, you know, you want to do very well, then you can always find other opportunities. Anything you guys want to add? Okay. So tips, this was also kind of embedded in our PowerPoint. The mental status exams are pretty important, especially when you're doing inpatient. This is just a portion of it, but essentially you'll evaluate the patient based on their appearance, their behavior, their mood, their affect, their thought process. And you don't necessarily do this, you know, with them, or this is based on your observation while you're interviewing them. So you would walk into the room while you're asking them questions about, you know, how they got there, anything about their past medical history or their psychiatric history. And then after, you will kind of do this evaluation on your own, not with the patient. They shouldn't really necessarily be aware that you're doing this evaluation.
The thing about psych is for when you're doing your history and physical, this mental status exam is your physical. And it's like Natalia said, like we didn't have our stethoscopes for most of our rotations. You're not going to be listening for heart rate and respirations and things like that in most patients. This is really what you're paying attention to for the most part when you're evaluating a patient. When you do your OSCE, like your standardized patient exam at the end of the rotation, that is like part of your grade. This will be, it's really important for you to know this. Like I literally like couple days before my OSCE, I just started like training myself. Like my sister was visiting and I was like, time me. And I was like, I need to be able to type the whole mental status exam in like less than a minute and a half because I'm, you know, don't have a lot of time in the actual OSCE. And I'm a person who's like, I want to talk to my patient for like an hour anyway. So I'm not buying myself any extra time. But it's completely different than the physical exam you'll do on any other OSCE. So you really want to learn this for the OSCE. And if your school does the LCSE at the end of the year, then you'll definitely have to revisit it as well.
Yeah, and just to add to all that we're talking about, note taking is very different when you're writing your notes in psych compared to all the other rotations. So I definitely recommend, and every attending is very different, in particular about their notes, and psych is very different to any other specialty. So I would recommend looking at your attendings' previous notes, your residents' previous notes to see what they like. I had some attendings who wanted very detailed psychiatric history notes. I had other attendings who wanted very little psychiatric notes because of and using specific legal jargon. Especially if you're Baker acted, for example. So look and ask for specifically about the note taking, what your attendings want.
Awesome. So now for the shelf, we'll talk a little bit about some study strategies that might help you to succeed in your shelf exam. You definitely want to learn a lot of the material early. Like Chuck was saying, a lot of the material has already been covered in step 1. But now you kind of have to apply it in the clinical setting. And I think the best way for this is to do a lot of practice questions. If Kiki or Chuck want to jump in and, you know, say anything otherwise, feel free to add, but I feel like questions were definitely the most helpful. UWorld tends to be very popular. Some people use Amboss, but I think UWorld is like probably the most used tool in terms of practice questions. Some people like to supplement with like repetitive materials, so like flashcards. Some people really like Anki and swear by it. Some people are visual learners and they'll use YouTube and online med ed, which is kind of like a guided videos in regards to topics. And then quick reviews before the test that I thought were very helpful. Emma Holiday, she did like a review and she's posted on YouTube. There might be a few things outdated, but it'll be noted usually like in the comments, or you'll kind of pick up on it. But Emma Holiday, it tends to be a really good review. Some people listen to her on 2x speed and just like go through everything surface level. I think it's really helpful. Dr. High Yield is also very helpful. And this applies for most rotations. And then you want to do practice exams. So you always want to simulate what test day is going to be like. And I think the NBMEs are very helpful for this. Keep in mind on their official website, they're about, I think, $20 per test. But as a disclaimer, you might want to ask your upperclassmen, see if they have any ideas of how you can get practice exams. Moving on. So podcasts, some people listen to podcasts like on their way to their rotation, on their way back, if they want to study lightly or feel productive. And then books, but just keep in mind some books can be a little bit outdated. But yeah, anything you guys want to add that has helped you guys for the shelf?
I just wanted to put in a word for AMBOSS. When I was in my psych rotation, I wasn't using AMBOSS at all. And then after psych, I had a couple rotations that were a little rough and I struggled. And so I kind of had to revamp my whole study routine. And I ended up starting AMBOSS like halfway through the spring semester. And I honestly like it more than UWorld. I think that UWorld, and this is like in general, not just for psych, but just in general, I think that UWorld loves to ask you really random questions about the most obscure things and make you feel super dumb for not knowing a thing that I work with a tutor and he's like, what is that? But AMBOSS I thought was really good because it covered a lot of high yield topics and you can kind of adjust it for how high yield you want it, like how much detail you want to see. And one thing that I like is whenever I do a problem set with AMBOSS, at the end of it, it'll say, hey, you missed a bunch of questions on bipolar disease and transplantation. So why don't you read those articles, which kind of helps me review. And then I'll do like a targeted QBank session on that specific subject. So not only does it make me see something twice, but then also I get to break up the sessions where I'm getting like 40, 50% with like 80 and 90%, which, I'm getting that because I just read the article, but it also helps me not spiral into like a discouraging place where I don't want to study anymore because studying, it's a whole cycle. So I'm not like trying to sell anybody AMBOSS or anything. I don't have a code for you or whatever, but if you try UWorld or if you try Anki and it's not working for you, AMBOSS is something you could try.
So I just want to hop on and reiterate what Chuck just said. She said it perfectly, so I'm not going to go into too much detail, but I 100% agree with her. Psychiatry was one of my earlier rotations, and I did really well on the shelf. And I accredit that 100% to AMBOSS. I noticed that the shelves that I did the best in were the ones that I really used AMBOSS. So looking at the articles, seeing exactly, okay, I'm not doing really well with bipolar. I can't pick it up. Why am I not picking it up? Reading those articles in AMBOSS and then trying to do it targeted just on like bipolar or whatever you're not doing well in really helped me too. UWorld, everyone does UWorld. So it's really, I think it's hard that since everybody does UWorld, everybody kind of knows all those questions. But if you really want to do really well on the shelf, I recommend using AMBOSS because it gives you just more questions. And I think the more questions you do, the better you're going to do on the exam day. At least that's how it is for me. Especially if you're struggling in certain subject areas, definitely use AMBOSS. I think it's a great tool and it's kind of not really talked about that much, I think.
Yeah. And then you can also use like the free trial. If you hadn't like signed up before, there's always a free trial. I think both are really good tools. I used both for psychiatry since there weren't that many questions on the UWorld bank. And I think that really helped as well.
One thing I wanted to throw in there, I'm sorry, I keep us on this slide. I just wanted to say something really quick. A lot of people after the first 2 years of med school have themselves in their study routine and they know an Anki works for them or Anki doesn't work for them. And, they know exactly what they need to do and they did great on step with what they were doing. And then they get to third year and find that it's not working for them anymore. Some people keep doing the things that they were doing before. But if you get to a place where whatever you were doing to do as well as you did on step isn't helping you anymore, please do not be afraid to ditch it. Try something new, like open up a new resource, look into a book, do Anki if you weren't before. A lot of people, once they're in that routine, they're like, well, I've survived this far, so I should just keep like ramming my head against a wall doing this. even though it's clearly not helping. You just got to break out of your box and try something new. Cause like I said, I was struggling and then I completely flipped it on its head. And now I'm like comfortable, you know, I'm not like the best student, but you have to give yourself grace to try other things.
100% agree with that. Okay, I felt the need to put this in because I felt that depression was one of the most high yield things, not only for the shelf, but for also the step 2 CK exam. What did you guys think? Kiki and Chuck, I felt like it was very high yield. I used the mnemonic Siggy caps, and I just would write it down on the sheet of paper that they would give me. And every time I would read the vignette, as soon as I saw, you know, one of those pop up, I would just check mark it. And as soon as I hit 5, I was like, okay, this, and it was 2 weeks. I was like, okay, this definitely qualifies for depression. So that really helped me. I just wanted to input that there to see if it would help anybody else.
Yeah, because they'll try to trick you. They'll have 4 out of 5. So you're like, oh, this is obviously depression. Like they aren't interested in anything and they're sad all the time and they're not eating. But like really, there's only 3. So the question's like, well, technically, that's not major depression because it's not 5 of them and they will mess with you on that. So this is a really good thing to know.
Okay, and I also wanted to put this disclaimer because a lot of times when we're practicing or learning or studying, you know, textbook things, we expect to show up in clinic and see like, you know, the textbook come to life, and that's not how it is all the time. The few times it is very, very, very interesting, but in psychiatry especially, you don't get a lot of textbook presentations. At least I didn't feel like that when I was doing my rotation. So you definitely, when you're in clinic, you know, take what you want to learn, write down the diseases that came up or the disorders, and then go home and study them. But it's not always going to show up like that in clinic. And a lot of also disorders might be stereotypes. So you might expect, for example, a patient with schizophrenia to look a certain way or act a certain way, but it's not always as we would expect stereotypically. So I just wanted to put that out there for you guys to be aware that just because you show up to clinic doesn't mean that you don't have to study for the day. Okay. So prep for step 2, it is definitely a part of the step 2 CK exam. It might not be as high yields as some other of the specialties that are included on there or the topics, but there is a lot of overlap in psychiatry with, for example, pediatrics, OBGYN, medicine. So just, even though it doesn't seem like there's a lot of psychiatry, it's there because sometimes they'll fall under other topics. But you definitely want to know, you definitely want to know the time frames of the disorders. I think they really try to trip you up with those. So for example, acute stress disorder versus PTSD, postpartum blues versus postpartum depression. Those are some examples. And then there's also certain disorders that are kind of have similar names just because they're associated, but they're not exactly the same thing. So don't let, for example, schizophrenia versus schizophreniform versus the personality disorders of schizotypo and schizoid mix you up. Those are very difficult to kind of keep apart, but those are things that they will try to trip you up on. So make sure you get it pretty straight in your head. You don't need once I did psychiatry in the very beginning of third year, I wouldn't recommend reviewing it every single day for the next 6 months until you take step 2 CK. I think it was very doable to review prior to the exam on your dedicated portion. And then of course, practice questions and practice tests are your best thing. And then online med ed, AMBOSS, Emma Holiday, Dr. Highfield, those kind of condensed reviews are really good for those last minute kind of refreshers. Anything you guys want to add? No? Okay, good. All right, and then evals. So always assume you're being evaluated. Sometimes we think like, oh, you know, I'm just working with this resident. It's not my preceptor who's going to be writing my evaluation. So I can, you know, just chill around and, you know, talk however I want. Like, no, I would just always assume you're being evaluated because your residents will have input in your evaluation as well as patients will have input in your evaluation at some schools. I know at my school, we have to give evals to some of the patients. just keep that in mind. And then also be aware that just because you honor your shelf exam doesn't mean that you necessarily will honor your rotation, because your evals play a very high role. And if there's any like sign of lack of professionalism, or you're tardy, or you just were inappropriate, then that will, worsen your chances of getting a good score on your rotation. And then if you have the slightest idea that you want to do psychiatry, your evaluations are a good window of opportunity to ask for a letter of recommendation, which you will need when you apply to residency. And I think Chuck and Kiki, you guys would be way better at explaining this or about your experience, because you are going into psychiatry. Anything you want to add?
So for me, my rotation was only 3 weeks, and I only had one attending during the 3 weeks. So I was only able to get one evaluation from my rotation. But it was a really strong evaluation, so I was happy about that. So if you're applying to psychiatry, I definitely recommend trying to get letters of recommendations. You can always get them from other rotations. I think family medicine or peds is a great one to get letters of recommendation from. I did geriatric psychiatry, and we actually did a lot of family medicine during it, and we actually did use our stethoscopes, but that's very particular to geriatric psychiatry. It was inpatient, so that's why we had to like monitor their glucose levels, their blood pressures, all that while they're inpatient. I would definitely look into that, and also research is a great way to get letters of recommendation. I have a very good research mentors who will be writing me a strong letters of recommendation. So I would, just showing up, doing your best, and finding out from your upper levels, like who writes great letters of recommendation for psychiatry is a great way too, because you always want strong letters of recommendation. So finding out who is a strong letter writer. Also, if you're applying to family medicine or peds, I think psych is very prominent in those fields, even internal medicine. So you can always get a psych letter of evaluation when you're applying to those residencies as well. So if you're like split between maybe family medicine, maybe peds, maybe psych, I would definitely get a letter from psych.
And I will say this, as bristly as I get about like stereotypes about psychiatry, your attendings and residents are psychiatrists because they understand people and they are getting to know you as a person. So the evaluations that you're going to get from them are going to really speak to the kind of person you are and the kind of doctor you're going to be. And they'll be very insightful in that way. That has been my experience so far. And my mentor in psychiatry will be writing me a letter. And I know that she's going to have a lot to say just about me and the work that I do in psychiatry. So like Kiki was saying, like if you want to go into family or peds but those are like going to be the closest ones, but any subject that you, or any specialty that you want to pursue, you're going to see psych patients. I'm already telling you right now, you're going to see psych patients no matter where you go. And so having a letter from a psychiatrist that really gets into the kind of person you are and the kind of motivations that you have, I think could be a really helpful factor, especially depending on what you want to do.
And then we kind of already touched upon all of our like individual experiences throughout the slides, but if there's anything you guys want to add, feel free. And then any final thoughts that you guys have for everybody that's going to be rotating through psych?
My final thought is just really valuing the connection that you have with a patient. And obviously throughout medicine, you're going to be doing this. Throughout third year, you're going to be forming connections with patients. But when you're sitting in a room talking to someone about like their emotions and their mental stability in that moment, it can get really difficult to like feel that connection with the patient, but really practice being curious and asking for more information. And, even if you're like, why am I going down this rabbit hole? The patient probably wants to talk about something and you can get it out of them, and that can help you either treat them or at least, build that link between you and them so that they trust you as their mental health provider. One thing Kiki said before about like talking to your attendings about how they approach difficult subjects like suicidality, things like that. I think those are some of the toughest things that med students, like that's what they find the hardest, because you don't want to be like, hey, so you want to kill yourself? But the thing is, like, that's kind of what you do, you know, obviously you're more diplomatic than that, but you ask directly. You don't say, you don't dance around it and hope they'll just kind of like break and tell you. Like, you ask them, are you having thoughts of hurting yourself or someone else right now? And that is a really hard thing to imagine if you haven't done it before, but patients will answer you directly when you ask them directly, as long as they feel like they're in a safe space that you've created throughout the interview. So really like value that link that you have with patients, because psychiatry, I think, is the place where you're going to be able to practice that the most of all the rotations, in my opinion.
Yeah, and I would agree with that. I just think for me, the main thing was to keep an open mind. I think there's a lot to learn from the psychiatry rotation, even if you don't want to go into psychiatry, and a lot of things to learn from seeing patients within the psychiatry, field. There's just so much to learn, so you can just be a overall more compassionate and empathetic provider, and just really put yourself in your patient's shoes and see how you can fulfill their needs and how you can address their biggest concerns.
I will also say learning how to have these conversations are really difficult. And I always say that to be completely honest with your patients, because sometimes they're going to ask you difficult questions, but learning how to respond to it is really important. So I've had patients ask me like, do you think I'm crazy? Or they had some thought in their mind. They think that, like, I had one patient who thought that the nurse was poisoning her and asking me like, do you think she's poisoning me too? And so learning certain phrases, being like, I think that this is really distressing for you, but not saying like, oh no, this person, like, not blatantly denying like that person is not poisoning you or your hallucination is not there. You have to figure out how to have the conversation with the patients. So I highly recommend at least the first day trying to shadow and watch to see what your residents, how do they phrase and how do they direct their patients. I want to open it up to any questions anybody might have.
Oh, I was just gonna say there's a question in the chat. What rotation we found the hardest and why? And that's a really difficult one because, and it's hard to answer too, because it's different for every school, every program, depending on how nice the people you work with are, depending on what the hours are like. I would say the most difficult one for me was OB, just because where I am, the OB program is a little bit toxic. And so I just didn't like dealing with that. And the hours were pretty rough as well. But I'd love to hear the Natalia and Kiki's thoughts on it.
So my first rotation was psychiatry. And then right after that, I went straight into internal medicine. Internal medicine was probably the hardest one for me. Ironically, though, it was the one I did the best in out of all my rotations. And I'm not going to go into internal medicine, but I think knowing that it was such a hard and broad specialty and shelf and everything, I really put like my all into it. Really tried so hard to learn everything possible for that exam, just because it was very, very, very dense. So I think that was the hardest one for me. The schedule wasn't too bad though. Just the content.
For me, I don't think there was like one rotation that was the hardest. I think there was different aspects of each rotation that was hard. So like for me, internal medicine, inpatient was really difficult because I was in a hospital that was and we had to do 6 days a week for 4 weeks, inpatient, very long hours. And I don't like rounding and rounding and rounding. I don't find it to be the most fun thing. And sometimes our rounds we would start at 7 a.m., but we ended at like 2 p.m., depending on your attending, just rounding. And then afterwards you have to write your notes. So that's what I found hard about internal medicine for me. But then outpatient internal medicine was amazing and I loved it. So I can't say internal medicine was the hardest because I loved a part of it, but then the inpatient side I didn't like as much. I found the internal medicine shelf to be easier than other shelves. I think the hardest shelf for me was my pediatric shelf. So it depends on I think there's different aspects that are hard. Also, peds was my first rotation, so maybe that's why I thought the shelf was the hardest. I didn't know how to prepare. So
The next question is, do you have suggestions for the order of rotations? What would you recommend starting with, putting in the middle, and or possibly ending with? So this is going to be different for everybody, depending on what you want to go into. And it also, like, a lot of people will strategize, like, you don't want to do what you want to go into super early on because you won't be very good at being a third year by then, but you don't want to do it too late because there's going to be a problem getting letters in time for applications. I think a lot of that is a little more myth than people say. I think that, you know, my psych mentor, she wanted to be a surgeon for her entire third year, and she had psych last and then decided she wanted to do it. And now she's an amazing psychiatrist. So I don't think that you are as limited as people will say. The only thing that I would say is I would recommend doing internal medicine before surgery if you can, because there's a huge overlap on those shelves. Like, a lot of people will say that surgery is just an internal medicine exam. And that wasn't exactly my experience, but there's a lot of IM on it. And I felt more prepared for it because I had done IM before. And now that I'm at the end of the year, I would say family is maybe better to take a little later, just because there's IM and OB and peds on family. And when I took family, I had not taken peds yet. So I really struggled. And now I'm reviewing family stuff in preparation for step 2. And every time I get a peds question, I'm like, oh, if only I had known this back then, like, because family just covers everything. But it really is according to your preference, and you can pass shelves even if you haven't done what I just said is like a prereq for it. Like, it really doesn't matter the order, you can succeed. But those would maybe be some tips I had.
I think a lot of medical students stress about the order of the rotations, and I really don't think it matters that much. I thought I wanted to go into OB-GYN or surgery, and I did OB-GYN first, and I did amazing in my rotation. I didn't have any, requisites before. That was my first one, and I did amazing in it, and I didn't like it. So, but I mean, that's the good thing why I did it first, because I realized, okay, I don't like this. I need to figure out something else. So I was really open to all my rotations afterwards. So, I mean, I think have faith that you will figure it out and everything is going to go fine. And if you don't get the schedule that you want, breathe. Everything's going to work out. You're in medical school. You're going to find your passion and just be open to where third year will take you. I will tell you, third year is my favorite year in medical school so far. So have faith that it's all going to work out. But I do say family, like my school, we all take the family medicine shelf at the end. Like, no matter where you had family medicine, you don't take it then, you take it at the end, which is really helpful for my school. And I agree. So yeah, it is really smart. I agree, because it's OB-GYN and peds, and that's why my family medicine shelf wasn't as hard. If I had taken it first, I thought it would probably be really hard. So that's a good point, Chuck, maybe doing family medicine later. And I did internal medicine last, and I thought that was helpful too, because I'm kind of like studying for step 2 will kind of goes together.
I agree. I did family medicine last, and then probably 4 weeks later, I took my step 2 exam. And I thought that it made the studying a lot easier, just because I had theoretically already covered everything at that point. I had just came out of studying for my family medicine shelf, and I was just kind of refreshing and doing more practice questions for step, and then just kind of knocked it out and moved on. Never looked back. All right. Any other questions before we kind of wrap things up?
Yeah, I have one question. I heard one of the speakers said Sometimes you're off at like an afternoon, but if you do not want to drop off opportunities, what opportunities would that be? And
If I heard the question correctly, it was if you don't want to go home early, like at the end of your psych rotation for the day, what other opportunities are there?
yes,
Kiki, you want to talk about some of the extra things that you did?
Yeah, sure. So it depends on where you're located. So I'm in Miami, Florida. I'm at UM. So there's depending on where you are. So there's Jackson, but we have a hospital just for psych, like a behavioral health hospital. And so within that, that's like all the psych units are together. So I was in an inpatient unit, and like when we were done rounding and I finished my notes and everything, there is a specific ED, like an emergency department that's just for psych patients. So they have to be medically cleared to go through our emergency department, the psych emergency department. So I went there to learn how to talk to patients in a crisis, and what that is like. So it's kind of like the ED version of psych. You can also, it depends. So really it's based on your attending. So just ask your attending or your resident, because sometimes your resident be like, oh, like go. And like I also was able to shadow, I guess you could say, in the outpatient department too, because it was right next to the inpatient department. So I went to the outpatient there too. And I just depends on your attending and your residents, and they'll be like, oh, I have a resident friend who's doing this right now. Do you want to go over there? And I just walked over. But it depends on, I mean, I also don't think you have to do that at all. Like I just did it because my rotation was so short. It was only 3 weeks. I was like, and I was like, okay, I already know I'm not going to do OB-GYN. I need to figure something out. And I was like, I wasn't thinking psych before, but I like it. So let me look like I'm doing inpatient. Let me try outpatient, see if I like that. So that's why I did it, because I wanted to see if this was going to be what I wanted to do long-term. And that is what I want to do. So I was happy I was able to figure it out. So I don't think that you need to do extra time. I just did because my rotation was so short. And I was like, I need to figure out if I want to do psych for the rest of my life or not.
Yeah. I also think that there's going to be other rotations where you have the opportunity to leave early. And sometimes, you did a lot already for the day. Like, don't overkill. Sometimes also your preceptors want their own time. So like, if they insist that you go home and you're like, are you sure? And they're like, yes, don't just go home,
Yeah.
go home and study, rest.
If you want to impress your preceptors, I think maybe instead of spending extra time, an idea is to look up the bulletins or like journals and being like, hey, I'd like to do a little presentation for you, 10 minutes on this topic, on bipolar or something specific. And then you present to them and then you have a conversation about it. And I think that might it's less time consuming, but also shows like you're taking initiative and you're taking time to read journal articles and stuff like that.
Yeah,
so that's an idea.
I think that in psych, especially because every person's treatment is so individualized, because it's focused more on the person and like the emotions within the person, you will find very unique and special ways to go the extra mile, but you don't have to do it every day. So there was one time, we didn't get a lot of inpatient experience on mine, but we have an inpatient geriatric hospital out here that we did 2 weeks at. And I had this like old lady, and she had like super crazy dementia, and she would tell us about her husband every day. And every day you'd ask her questions and she would tell you the exact same things about her husband, like always talking about him. And then one day it was like one of the last days I was there, we got a call from a family member that her husband had passed away while she was in the hospital. And it was really devastating. And I kind of just felt like, well, I've been seeing this patient every day. If, obviously I'm not like the most important member of the team, I'm a medical student, but I've been a stable fixture in her life for the last 2 weeks. So I asked, like, can I stay behind? Can I be there for the conversation when you tell her about her husband? And so I stayed a few extra hours and, helped the people that I was working with until we waited for the social worker to come in with the patient. And like, that was a very unique, she's one of the hardest patients I had all year. Like, I think that was the first time I came home and like cried to my roommate. Like, that was really tough. But that, I didn't feel like I had to stay 15 extra hours every day. But that day I was like, I want to be a part of this. Will you let me stay? And they did. So I think that you will have patients in your psych rotation that you are able to kind of do a little bit extra to get the full picture of treatment if you want to.
Yeah, I just wanted to say that I put our contact information, our email again in the chat. If anybody has any other questions, but we are over time. So I'm going to go ahead and wrap it up to be respectful of everybody's time. Thank you for coming and joining the panel. Thank you to all the panelists for doing this. And I wish you all the best of luck.
Thank you, everyone.
No problem. Bye.